Today's discussion by Caroly is a very, very important discussion. It's about all of the physician and patient-reported survey tools that we use. So even though I asked Caroly to go through this, it is my expectation that every one of the fellows will know what this topic is in the same depth and understanding that Caroly did. I give her a lot of credit. I saw her initial presentation. She obviously read every one of the articles, and my expectation is that you all will do the same. So this is a bit of a long presentation, so I'm not going to go on very much. So Caroly, go ahead and take it away.
Okay, so good morning, everyone. To start the presentation, so we are going to start with the physician versus patient tool. So as the name says, physician-reported outcomes are outcomes that are observed, evaluated, and documented by a physician or healthcare professional. Obviously, these measure disease severity and clinical signs. The strength is that they are objective and reproducible, but the weakness is that they don't show patients' daily burden. Now, the patient-reported outcomes report a patient health condition, symptoms of quality of life that comes directly from the patient without interpretation by a clinician. They measure symptoms and quality of life. The strength is that they reflect the patient's experience, but of course, they can be subjective and sometimes less precise. This is a comparison between the physician and patient survey tools, and I'm going to go ahead and go further in each one of these. And this is another classification of the survey tools where with classification tools, clinical severity tools, and disease-specific quality of life tools. So we start with the SIP. It was developed in 1994 by the International Ad Hoc Committee of the American Forum and endorsed by the Society for Vascular Surgery. And it was incorporated into the reporting standards and venous disease in 1995. It underwent the first revision in 2004 and then an update in 2020. The purpose of SIP is to standardize language, to provide a common international framework for describing chronic venous disorders, to give a comprehensive description of the four dimensions that we know of the SIP, facilitate research and registries, and to give a clinical utility to help physicians classify patients consistently in practice. To understand the key aspects of SIP, we need to understand that it is actually like a descriptive snapshot. The sole purpose of SIP is to describe a patient's chronic venous disease status at a single point in time, providing a clear snapshot of the patient. And the core principle is reproducibility. That means that we classify the patient the same in different occasions by different providers also. And the important limitation is that it's a descriptive tool and it does not attempt to measure disease severity or the outcomes of therapeutic interventions. And this is very important because this is why other tools, other survey tools came because of the limitation of the SIP. The SIP components is an integrated classification system. We know this already, so I'm just gonna go ahead to the next slide because we all are familiar with the SIP classification. So the French study of the reproducibility of the C classes of SIP classifications, the findings of these studies were presented in the 14th World Congress of the International Union of Phlebology in 2001, and a conference of experts on the refinement of C in SIP was organized. The main findings of the French study and where they focused were on the reproducibility of the SIP classification. And they divided into intra-observer and inter-observer reproducibility. Intra-observer reproducibility is how consistent the same observer is when repeating a measurement or classification on different occasions. That means me as a provider classifying the same in different occasions the same patient, giving him the same classification. And inter-observer reproducibility is how consistent different observers are with each other when assessing the same patient or case. So different providers giving the same classification to the same patient. And the statistic tool that they used for this study was the kappa coefficient. That is a statistical measure of agreement between two raters that takes into account the possibility of the agreement happening by chance, with higher scores, of course, indicating more substantial agreement. The key findings of the study, as I mentioned, they focus on the reproducibility, and they found that the intra-observer reproducibility was good with high consistency, 85% of agreement, with a kappa coefficient of 0.54 to 0.86. And then but however, the inter-observer reproducibility was low with 47% agreement and with a kappa coefficient of 0.39 to 0.55. Now, reproducibility was also better for advanced venous disease, C4 and C6, than for less severe disease. And the reason for this is because there were ambiguous definitions between telangiectasia and reticular veins and varicose veins. There was not a consistent and clear definition for these, and that's why different providers will classify the patient like one in the telangiectasia and the other one will say is varicosity because of this limitation. Now, then, because of these French studies, they created this team to improve the C of SIP and then suggest a definition and refinements with an International Union of Phlebology Conference of Experts. So the C of SIP. Hello? Okay, so the CEO of SIP article, the aim of this article or this conference was to improve the poor inter-observer reproducibility by increasing the accuracy of clinical definition of cases, of classes, sorry. And then the purpose of the study was to evaluate limitation of the clinical C portion of SIP to address the low reproducibility, especially for poor inter-observer reproducibility, and to propose refinements and clearer definitions to improve consistency. So I already mentioned this before. They focus on clearer definitions for telangiectasias, intradermal dilated vessels less than 1 millimeter versus reticular 1 to 3 millimeters and versus varicose veins subcube more than 3 millimeters. They also clarify the definition of edema versus pigmentations versus lipodermatosclerosis. And then they recognize also chlorona phlegmatica as a clinical sign. And then the 2020 update of the SIP score came. In May of 2017, the American Venous Forum created a SIP task force and charged it to critically analyze the classification system and recommended revisions were needed. So the 2020 update key changes that they added the C0's definition clarification that they were symptomatic patients without visible signs as C0s. They also subdivide the C4 division in C4A, pigmentation and eczema, C4B, lipodermatosclerosis and atrophy branchi, and C4C, corona phlegmatica. And then they made emphasis on patient-reported symptoms in the classifications and standardized descriptions. The reason why they added corona phlegmatica as C4C is because they actually saw the corona phlegmatica is considered, they actually saw the corona phlegmatica patients are 5.3 times more likely to develop an ulcer. And that meaning that is actually an early signs of advanced venous disease. So this is like a resuming of what the 2020 update was and if of the changes they made in the clinical I already mentioned. On the theology, they further divided in secondary, like the secondary theology in intravenous cause and extravenous causes, like intravenous causes like DVT and extravenous causes like CHF. And then the anatomy part, they replace the numeric vein descriptions with the standard anatomical abbreviations with GSV, SSV, CFV. And then the pathophysiology was unchanged. Now we go with the SVP classification for pelvic venous disorders. The reason is because the SIP was a great tool, but it only was able to classify patients with with leg symptoms, but it was not able to classify the patients with pelvic disorders. So the SVP classification system provides a structured approach to categorize pelvic venous disorders based on key diagnostic components: symptoms, varices, and pathophysiology. So they focus on these three main topics. Um, to understanding the symptoms, they subdivided the symptoms in renal origin symptoms with the common manifestations of hematuria and left flank abdominal pain. In chronic pelvic pain, with symptoms perceived to originate from pelvic organs and structures typically lasting, and this is very important, more than 6 months, the venous origin pelvic pain is more likely to be associated with a prolonged postcoital ache, and the diagnostic indicators is the combination of the postcoital ache, and tenderness over the ovarian point. And this was reported to be 94% sensitive and 77% specific. And then the pelvic origin extrapelvic symptoms are in the female: pain, discomfort, tenderness, superficial venous thrombosis. They also associated the superficial venous thrombosis commonly associated with nosa finos varicosities and may be located in the vulva, posterior medial height, and on the male, testicular discomfort and infertility. Additional extrapelvic symptoms could be also sciatic pain, and then venous claudication. They further characterize the pain by location. It typically experienced in the thigh, buttock, or leg. The description is frequently described as a tight bursting sensation, and the trigger is an exertional pain, so meaning that it's brought by activity. It is activity independent. So unlike arterial claudication and PAD, this is not consistently associated with a specific walking distance. And it is diffuse, it generally not confined to a specific muscle groups. The relief factors are rest and leg elevation. And then varices, the venous system of the pelvis can be considered to consist in three distinct reservoirs where varices can develop or may develop. The first one is the renal ileum. The second one is the venous plexuses of the pelvis. And the third one is the pelvic origin extrapelvic veins. And we have a graphic here where you can see each zone. The pathophysiology domain is a comprehensive framework that integrates three crucial subdomains to understand the disease process: anatomic, hemodynamic, and etiologic. So this is the anatomy part. We know already these, the abbreviations with the main veins. The hemodynamic classification is similar to the one in SIP, with reflux, obstruction, both combined or none. And the etiology is divided in thrombotic and not thrombotic, or congenital too. And then this is a table that is how the SVP is scored. So we have here the symptoms, varices, and anatomy, pathophysiology, and etiology. So, and if we can see in this table, we can see if there is no pelvic symptoms is 0. And same like no pelvic varices. If we have renal is 1, pelvic is 2, extrapelvic is 3, and so on. We have here an example of a patient with chronic pelvic pain due to bilateral primary ovarian vein reflux. A dilated refluxing left ovarian vein, the black arrow, is associated with multiple pelvic varicosities, white arrow. Right ovarian vein reflux is also present, but it's not demonstrated in this image. and no obstruction of the left renal or common iliac veins or internal iliac reflux is present by ultrasound examination. So the symptom varices pathophysiology classification will be S2, pelvic symptoms, V2, pelvic varices, and pathophysiology is bilateral gonadal vein, reflux, and not thrombotic. The strength of this classification is that it's comprehensive, combines symptoms, varices, and imaging for a complete view, is standardized, enhance consistency in addressing pelvic venous disorders, is patient-centered, and it also supports robust research and multicenter trials. Then we further go with the clinical severity tools. We have all these we divide them in insufficiency tools and obstruction tools, and I'm gonna go ahead and elaborate more on this. So the venous severity scores, we have that the venous severity scores was based on Rutherford et al. At vascular surgery in 2000. And we have the venous clinical severity score, the venous segmental disease score, and the venous disability score. So when I was telling you that the SIP was a more descriptive tool, and it was not able to evaluate responses to treatment or outcomes to treatment. That's why they created these tools. Because, for example, if we treat a patient, if we have a patient that have a C6, active ulcer, and we do ablations on the patient, the more it can improve is to C5, like a heel ulcer, but it will not regress more because the skin changes will not change. So they needed a tool that actually evaluated the treatment outcomes for the patient. So as I mentioned here, the C provide a descriptive framework, but lacks dynamic outcome sensitivity for measuring treatment effectiveness. And in the late 1990s, the American Venous Forum and HOT Committee developed the severity score to address these limitations. The purpose of the venous severity scores is to provide standardized dynamic quantitative measures of venous disease to complement SIP classification, not to replace it, by adding dynamic assessment capabilities to the static descriptive framework and to allow comparison of outcomes across institution, therapies, and patient groups. So we start with the venous segmental disease score and the venous disability scores. These are actually more historical surveys. We don't use them anymore, but the venous segmental disease score actually was an anatomic integration that combined anatomic, pathophysiologic of the SIP elements for comprehensive assessment. It was an image-based tool, so it was based on venous imaging with Doppler ultrasound or venogram, and then it assigned points for reflux, obstructions in 11 venous segments. And the clinical relevance, it was the segments weighted for clinical importance. Propitels were higher points, 2, and perforated 0.5. On the venous disability score, it assessed the effect of venous disease on daily activities and patients' quality of life.
Skip this. All right, nobody
Okay.
uses this. Skip it.
Okay.
Thank you.
No problem. So we have now the venous clinical severity score. The key components is the modification of the SIP clinical score. So actually, when the SIP was introduced, it also had a SIP clinical score. So this is a modification of that SIP clinical score. So it has 9 clinical descriptions that I'm gonna go over later. And then each is graded 0 to 3, absent, mild, moderate, and severe. And it also gives points for compression and elevation compliance. And the reason behind this is that if a patient is compliant with compression stocking and they are actually symptomatic still, that makes them worse because they are already compliant with the conservative management. The total score is 0 to 3 points, and it provides a comprehensive clinical assessment tool that captures both symptom severity and treatment compliance. So we have the main topics: pain, varicose veins, venous edema, skin pigmentation, inflammation, induration, and also number of active ulcers, um, duration of active ulceration, and active ulcer size, and also added the compressive therapy of the compliance with compression. The revised Venus Clinical Severity Score, it was the revision of the VCSS represented a collaborative international effort to refine and improve the original scoring system based on years of clinical experience and research findings. This update version addressed key limitations identified in the original framework. So why a revision? Same as the SIP. It was the ambiguity in clinical description noted originally, the limited sensitivity, in early disease stages, C1 to C3, for the same ambiguity of definitions in telangiectasias versus reticular veins versus varicose veins. And then the reproducibility concerns, there was inconsistent reproducibility between observers and affected reliability of assessment. The key revisions were the pain assessments. They added also aching, heaviness, fatigue, soreness to the score. The varicose vein in this part, because the initial one, the varicose vein diameter, they said that it was more than 4. So this one defined it as more than 3 millimeters in diameter. The edema grading, they specify further anatomical extent. It was not only below the ankle or above the ankle, it was now ankle, knee for more precise assessment. They also clarified the skin changes with clear definitions for pigmentation, inflammation, induration with a specific criteria. And they also added corona phlebistatica, mild varicosities category for early disease detection. The revised ulceration criteria goes also over the ulcer number. The score 0, 1 to 3 ulcers presence, the duration, less than 3 months, 3 to 12 months, more than 12 months, the size, less than 2, 2 to 6, more than 6, and the healing status. They clarified the scorings for healing ulcers and longer and larger ulcer assessment. So we have the pretty much what was added, highlighted to the VCSS. And this is a timeline for us to better understand since the SIP was created, then the venous severity scores came in the 2000, then the revision, then the revised was in 2007, the revised VCSS, and then the latest update of SIP was in 2020. Now we have this validation study overview by Meissner et al. And this landmark study provided crucial evidence for the clinical utility and scientific validity of the venous clinical severity scoring system. So the objectives of this study was a correlation analysis of the VCS scores with C clinical classification to establish validity. It also evaluated the intra-observer reliability and inter-observer variability. The study design was a prospective study involving 128 limbs in 64 patients with various stages of venous disease. And then there were 3 observers, 1 vascular nurse, 2 vascular surgeons with different experience levels. And they used the VCS components score 0 to 3 across 10 items, including pain, varicose veins, we know this already. And also the SIP classification was also recorded for each patient to then correlate the analysis with the VCS scores. So the results, there was a mean VCS score for patients with no venous disease of 1.7, that means SIP 0, 14.7 for patients with active ulceration, and 0.84 correlation with a strong correlation between these two. So this means that the VCS scores increase progressively from CYP0 to CYP6, demonstrating excellent correlation with this between the CYP and the VCS scores. And then the conclusion of the study is that VCS is a valid and reliable tool for evaluating chronic venous disease with a strong correlation to established classification system like the CYP, and then provides dynamic measure of severity correlation with CYPs, enabling longitudinal tracking of disease progression and treatment response. Now we are going with the clinical severity scoring system for post-thrombotic syndrome. So we are gonna go also really fast in the Branches clinical score. Is also historical tool developed by Branches et al. In Netherlands to quantify the post-thrombotic syndrome severity. It assessed the subjective symptoms and objective signs, and each item was scored 0 or 1 or a total score of 0 to 11. And then the symptoms assessed were pain, cramps, heaviness, paresthesia, pruritus, and then the signs, edema, induration, hyperpigmentation, redness, etc. The strength of this classification score or this severity score, sorry, is that it was the efficiency was quick and straightforward to administer. It provided a clear scale for PTS severity, and then it was widely adopted in clinical studies. However, the limitation was that it was a binary 0 to 1 scoring and may lack nuance, and the reproducibility was subjective. Because it was a subjective interpretation, it could lead to observer variability. The Whitmer Clinical Severity Score was developed by Whitmer in Switzerland in 1978. So it was actually the first standardized clinical classification for chronic venous insufficiency. It actually preceded the CYP classification by more than a decade. And it classified CVI into stages based on clinical signs, ranging from asymptomatic to severe skin changes and ulceration. Each stage represented the increasing severity of venous disease. The strengths, it was valued for its baseline simplicity and ability to model disease progression, and it was particularly useful for epidemiologic studies. But the limitation is that it was primarily focused on clinical observation, lacking objective diagnostic parameters. The Ginsberg Clinical Severity Score was developed by Ginsberg et al. In 1995 in Canada, and it was an early attempt to standardize diagnosis of post-thrombotic syndrome in research. The design was much simpler than the Villalta score, which I'm gonna mention in a bit, and it was widely used in early post-thrombotic syndrome epidemiology and anticoagulation studies. It was a binary study diagnostic tool. It was like yes or no for the questions, and the PTS diagnosis was diagnosed if both of these conditions were present: persistent leg symptoms for more than 1 month, occurring more than 6 months after a DVT, and objective clinical signs of venous disease in the same leg. So this is the table of the scoring with the question, and it was only a yes or no question. The strengths, it was the simplicity. It was very simple and easy to apply in clinical trials. It had high specificity because it required both symptoms and signs. And the epidemiologic value, it was useful in large-scale epidemiologic studies. However, the limitations were that there was no severity grading that cannot assess severity like mild versus severe, and the low sensitivity was less sensitive than the Villalta, and it may also underdiagnose early PTS, and then the reproducibility issues was lower across observers. So because of this limitation, it was largely replaced. So the Villalta clinical severity score, that is actually the gold standard, was developed in 1994 by Villalta and colleagues in Italy. The purpose of the study was designed to diagnose and grade post-thrombotic syndrome after DVT. It was adopted internationally and validated in multiple populations, And as I mentioned, this is the gold standard, and is recommended by the International Society of Thrombosis and Hemostasis as the gold standard tool. The structure of this score is that combines the patient-reported symptoms and clinician observed signs. The symptoms evaluated are pain, cramps, heaviness, pruritus, and paresthesia, and the clinical signs, again, the same: edema, skin induration, hyperpigmentation, redness, venous ectasia, and pain on calf compression. Each score is 0 to 3, absent to severe, with a total score range of 0 to 33. So this is the table score for the Villalta. So we have the symptoms, the signs, none, mild, moderate, severe, and the interpretation score. If it's 0 to 4, is no disease, negative for PTS, is 5 to 9 is mild, 10 to 14 is moderate, and more than 15 or more is severe. The strengths of the Villalta is that it's a comprehensive tool, includes both symptoms and signs. It has international validation. It is responsive to clinical changes after interventions and is the gold standard. However, the limitation is that it requires trained clinicians to assess signs to decrease the interobserver variability. It has a disease overlap with other venous diseases symptoms like chronic venous insufficiency, and it has subjective elements like pain, heaviness that may vary between patients. And also, it's not designed for general venous disease. It's specific for post-thrombotic syndrome. There was this study, the scoring system for the post-thrombotic syndrome, that they evaluated the main scoring, or they were reviewed the main scoring system that I just mentioned before. They also evaluated the SIP. They added to this, the SIP and the VCSS. It was a systematic review of studies assessing post-thrombotic syndrome scoring systems. It was a database research. They used this database, Medline and BASE, and the inclusion criteria were studies evaluating reliability and validity responsiveness. The research focus was on scales used for diagnosis, severity, grading, and monitoring. So the results of this study show that the Villalta was the most validated, with strong correlation with quality of life and venous physiology. Ginsberg was simple but too restrictive and identified fewer cases. Brandeis had severity grading present, but it had limited reproducibility. Whitmer and SIP was descripted but not sensitive to change after treatment. And then the VCSS was useful for chronic venous disease but less specific for post-thrombotic syndrome. So detailed conclusions. Villalta is recommended as the standard for post-thrombotic syndrome. It is important to take into account the combined assessment, like combining Villalta with veins for quality of life assessment, improved assessments. It has historical value. Other scales provided historical value, but were limited in current use. And the Villalta is best for clinical practice, trials, and longitudinal monitoring. This is a summary of the post-thrombotic syndrome tools that you can go back and refer after I finish my presentation. Then we have disease-specific instruments of quality of life questionnaires. We start with the CIVIQ, the Chronic Venous Insufficiency Questionnaire. It was developed in 1996 in France, making it a pivotal moment in venous disease assessment methodology. It was the first disease-specific tool because we already had health-related questionnaires, but we didn't have venous insufficiency quality of life tool. And it was pioneered as the first disease-specific quality of life tool for chronic venous disease, filling a critical gap in patient assessment. It is comprehensive. It is a comprehensive assessment. It's designed to capture functional, psychological, and social impacts beyond symptoms. providing a holistic view of disease burden, and it has international validation. So there are versions of this CIVQ, the CIVIQ 20, the 14, and the latest, the 2 is not actually the latest, is considered to be the same as the 14, but with fewer questions. So we have the structure of this score is the pain domain. It assesses various pain experiences related to venous disease. Physical function evaluates impact on daily physical activities and mobility. Measures also the emotional and mental impact, and the social function also assess effects on social relationships and activities. So we have here an example of the questionnaire. So it will ask the question: during the past 4 weeks, have you had any pain in your ankles or legs, and how severe this pain has been? And it ranges from no pain to severe pain. The 14 what represented a streamlined version that maintains the comprehensive assessment capabilities while reproducing patient burden and administration time. So because it was a fewer questions, it was less time for the patients to fill this questionnaire. So that's why it was making this tool more practical for routine clinical use. And then we have the varicose vein symptom questionnaire, the VVSYM-Q. It is a patient-reported outcome tool for varicose veins, and it represents a focused approach for symptom assessment, specifically designed to capture daily symptom burden experienced by patients with varicose vein disease. In response to evolving regulatory landscapes, the VVSYM-Q was developed in alignment with FDA guidance for patients-reported outcome measures, and it has clinical trial applications, facilitates robust evolution of the treatment extensively used, and efficacy and patient outcomes for new therapies, and it's a symptom-focused design. The tool core design emphasizes patient-centric symptoms assessment, providing a granular view of a daily impacts of varicose vein disease. So it focused on these 5 symptoms: heaviness, achiness, swelling, throbbing, and itching. But I wanted to highlight here that the VVSYM-Q is actually a proprietary tool. That means that you have to pay a license fee to use it. So the Vascular Quality Initiative has gotten around this by using the HASD version or the HASD score, which is the same: heaviness, achiness, swelling, throbbing, and itching. This is example of the score. The stress of this score is that it's symptom specific, focus only on patients' daily venous symptoms. It's easy to use. It has short 5 questions, quick to complete, is FDA accepted, is sensitive to treatment related improvements, and making it available for outcome assessment. And it detects treatment efficacy for patients' perspective. The limitations is that it measures symptoms only, not clinical signs or severity. It requires daily diary completion, and adherence can be challenging, and is less useful in patients with minimal or atypical symptoms. We have also the Aberdeen Varicose Vein Questionnaire. It's a patient-reported outcome tool for varicose veins also. So it was developed in Aberdeen in 1993. It was the first disease-specific tools, and it revolutionized venous disease evaluation by being the first questionnaire-specific designed to assess the impact of varicose veins on a patient's quality of life, and it also has international validation. The structure is similar: pain and achiness, comprehensive assessment of pain levels and aching sensation experienced by patients, cosmetic concerns, assessment of appearance-related concerns in their psychological impact, compression use, the heaviness and swelling, daily activities impact, and anatomical mapping. So includes a diagram shade of varicose vein distribution for visual assessment. Then the strength is that it's a target assessment for venous disease, is comprehensive capture of impact on daily life, and visual mapping aids assessment clarity. The limitation is that it can be longer to complete, of course. It can be, the scorings may appear complex and primarily focus on patient-reported quality of life. We have the VANS Quality of Life Symptom Questionnaire that was developed in the 1990s and early 2000s. It has dual applications to assess chronic venous disease and DVT. It has international validation also and dual components. It has the venous specific quality of life and venous symptoms components. The structure is symptoms, daily activity, psychological change assessment, and global assessment. And this is an example of the score here. So the key aspect of the scoring process include raw responses are collected from all 26 items. So this is a very comprehensive questionnaire. The raw scores are then converted into Z-scores, and the composite scoring is utilized for specific dimensions. The VANS quality of life is a subscale measure that the impact on quality of life, where higher scores indicate better quality of life. So this is like the inverse. And then the VANS symptoms is a subscale focus on symptoms burden, providing a clear picture of symptom severity. The strength is that it's validated for chronic venous disease, varicose veins, and DVT populations, is sensitive to treatment changes and clinical improvements. It is translated into more than 20 languages and is for international use and covers both symptoms and quality of life domains comprehensively. The limitation is that the scoring requires a statistical handling, like as I mentioned, the conversion of the to Z scores and expertise, is less user-friendly and routine clinical practice settings, and is no varicose vein specific, is more general for venous disease focus, and is less used in FDA regulatory trials. The VB-SYNQ is preferred. And we have the Charing-Cross Venous Ulceration Questionnaire. Is a patient-reported outcome measure for specifically for venous legs ulcers. So the CXVUQ addresses a critical gap in venous ulcer assessment by providing a condition-specific quality of life tool that captures the unique challenges and impacts experienced by patients with venous ulcers. It was developed in this Caring Cross Hospital between 1996 and 1999. The specific focus was on the venous leg ulcers, as I mentioned, and it has also international application. The structure it has the main cosmetic concerns, where the appearance issues and embarrassment related to visible ulcers are taken into account, the domestic activities, mobility limitations, and household chores difficulties, social interaction with relationship impacts and social activity restrictions, and emotional status with frustration, worry, and depression related to the ulcer presence. The scoring system is a Likert scale rating. Items are scored on Likert scale from 0, no impact, to 4, severe impact, for a standardized assessment. It has a score transformation, so the total score is transformed to 0 to 100 scale for easy interpretation and comparison across studies. And higher scores indicates worse quality of life, providing clear directional understanding for clinicians. And the treatment sensitivity is sensitive to ulcer, healing, and recurrence, making it valuable for monitoring treatment outcomes. This is also a comparative table analysis of the quality of life instrument. And then we have the general health instrument, quality of life instrument, like the SF-36 in venous insufficiency. So it is a short form health survey. It is a generic tool, as I mentioned, it's health related, it's not disease specific, but it's widely used, benchmark quality of life across conditions, and generates PCS physical and MCS mental topics or structure. The structure is physical functioning, so it address the physical functioning, the daily activities and mobility assessment, the mental health, the emotional health, social functioning, physical, bodily pain, general health, and vitality. So we have this study, the reliability and validity of a specific quality of life assessment questionnaire related to chronic venous insufficiency by Almeida et al. It is a comprehensive review of the health-related quality of life questionnaires in chronic venous insufficiency. Multiple tools were analyzed, the CIVIQ, veins, the Aberdeen, very short CCVUQ, and VLU quality of life. It has extensive data with 27 studies included across multiple populations. It is a registration systematic review registered on Open Science Framework. The inclusion criteria were studies evaluating reliability, validity of health-related quality of life questionnaires in CVI patients, and the exclusion criteria were duplicates review or post-thrombotic syndrome studies. It showed that CIVIQ 20 and CI in the 14 version 2 were adequate reliability and discriminated disease severity. The veins quality of life symptom was a reliable, but it was limited. It had limited ability to discriminate severity with correlation with the SF36 mental component. The Everdeen was questionable reliability, had questionable reliability and validity, and the CXVUQ had good reliability and validity, and it was adequate for venous ulcers. The top recommendations were CIVIQ 14 and 20 as the most reliable and valid tools for chronic venous insufficiency assessment. The secondary options were veins, quality of life symptoms, useful for limited for severity discrimination, and caution was required when the Aberdeen was less reliable in caution with interpretation. And of course, they show the need for further cross-cultural validation and longitudinal studies. We also have I'm actually gonna pass this study. I'm gonna go straight to sorry. So this study was the severity of disease and treatment outcomes of anterior accessory great saphenous vein compared to the great saphenous vein. It was done in our institution, Dr. Diol, Lacampal, and Dr. Papas. The study highlights the under-recognition of the AAGSB reflux that is common, but is often under-recognized, that it has comparable severity to GSV disease. It also has the treatment also had similar outcomes. So endovenous therapy for AAGSV shows similar short-term outcomes to GSV, and comprehensive treatment of tributary. So it also highlighted that tributary treatment was necessary for optimal long-term results. So the objective was a disease comparison and outcomes of treatment of isolated AAGSV reflux versus isolated GSV reflux, treatment efficacy, and outcome measures. So the outcome measures, they actually use the RVCSS and the patient-reported quality of life, the CIVIQ 20 outcomes. So it was a multi-center retrospective cohort study between 2015 and 18. It included 31,186 patients, 49,193 limbs for CVR. The study groups were two, the isolated AAGSV, 91 patients and 103 limbs, versus isolated GSV, the vast majority, 7,704 patients with 10,371 limbs. The outcome measures were the revised venous clinical severity scores, and the CIV-IQ-20 quality of life survey. And the interventions were ablation alone versus ablation plus phlebectomy. So the results, they found out that the RVCSS there was no significant difference between AAGSV and GSV groups at baseline 1 month or 6 months. So this tool was the same. The quality of life tool actually in both groups improved at 1 month, but at 6 months, the AAGSV ablation group actually worsened. And then, however, when phlebectomy was added to the AAGSV ablation, then the quality of life score stabilized and were comparable to the GSV group. So the conclusions were that the AAGSV reflux has similar severity and outcomes to GSV reflux. Ablation alone may be insufficiency for AAGSV, and that's why tributary treatment improved the quality of life, like the phlebectomies. And then the insurance coverage should recognize AAGSV treatment as medically necessary, and the study supports need for, and there was a study support need for comprehensive treatment strategies for AAGSV disease. And the reason why I added this study, it was to highlight how we need both physician-reported outcomes with patient-reported outcomes, because as I mentioned here, the RVCSS there was no significant difference between the groups. The quality of life actually worsened in the AAGSV ablation alone, but then was comparable when ablation was added, when phlebectomy was added to ablation in this group. So these highlight the importance of using both tools for studies. And then this is a review of the uh, venous comprehensive venous outcome assessment. It's a really nice review. You should all read it, and it highlights and the main tools that we use. And this is it for me. Thank you very much.
So thank you, Caroly. This is for the audience, this is an extremely difficult talk to give because, I mean, let's face it, it's not a very exciting topic, but these are the instruments that we use when we assess our patients. So for the fellows in particular, if you want to become a specialist in venous disease, you have to know these assessment tools. You have to know the physician-reported tools. You have to know the patient-reported tools. You have to know what the strengths and the weaknesses are of all of these tools. You have to keep up with all the various revisions that were done. So again, I want to repeat my initial comment. Even though I had assigned this topic to Caroly, it is my expectation that every one of you as fellows will read on these papers that were outlined. The papers that she presented are the classical papers on this. The validation study by Meisner, the review studies by Almeida, all of those papers are must absolute reads. And I will guarantee you, when you sit for your boards, you're going to see these questions on the boards. So Caroly actually has a much larger presentation than this. It's like double the size of this. I will ask her to send that to me, and I will post this to the share drive if you want to go back and use it as a reference, because there's a tremendous amount of information here that is very, very important for all of you. And again, I want to go back and I say to the fellows, it is my expectation that you all read those papers. You will understand these survey instruments and how they're used, and you will be very facile. And the other thing is, if you don't understand these survey instruments, when you're reading the literature as you go on in your career, you're not going to know whether or not those papers are valid or not if you don't understand the survey instruments that were used. So I'm not encouraging you, I'm not imploring you, I'm actually requiring you to make sure that you go and you read these papers and you understand this topic thoroughly. Okay, so we have just a couple of minutes for any brief questions if anybody has a question for Caroly. All right, so listen, I know this is a really tough topic. I want to congratulate you, Caroly. I said this is the level of presentation I expect from the fellows. This was in-depth. She obviously read every one of the studies. She knows them inside and out. She can speak intelligently on it without making any mistakes. This was a high quality presentation, and I'm very, very proud of you. This was a good talk. Good on you, Caroly. All
Thank
right. Happy Friday, everybody. Enjoy your weekend.